All right, thank you very much, Dr. Fiona. Again, welcome everyone to our this new installment of our usual seminars that we have in the evenings. This will be focusing on geriatric medicine. The idea here is that we have got a complex type of patient, quite a unique type. At some point, you might have been told about little babies not being exactly small adults. I would probably say the geriatric patient is exactly an older adult. Something is different about them and needs a lot of modification of your care and approach to care. So this installment of our talk will give us a bit of an eye-opener into the uniqueness of these patients and what we should do to ensure that they sail through care the most appropriate way. So today, why should we study geriatrics in the ICU? Why should we focus on the geriatrics in ICU? Number one is that you're going to grow old, for sure. Our life expectancy is increasing. It's going to be a much better expectancy than that of our ancestors. As long as you drive safely and don't drink bitter things and terrible things, you're likely to live long. Of course, take care of yourself. With increasing aging comes alterations in physiology, right? From immune to physical to functional, all of these get altered. And as such, there's a burden of increasing background chronic illnesses that have been accrued over time, and they become part and parcel of the patient. They affect the patient's performance during their best health, and definitely must influence their chances and journey through acute illness, much so critical illness. So along with this complex physiology is the fact that their physiological reserve is significantly decreased. So our hope today is that we shall sail through with a few objectives. First, to understand some of those physiological changes that happen with aging, understand the scoring tools that might guide us in guiding care, in setting up care approaches for these patients based on their needs. And then we shall look at the special consideration of care of these patients in the ICU. Then there's life after ICU. Now we need to be able to look into how these patients survive after ICU and what should be done to keep them going in the right direction. So we've got an action-packed evening and a number of presenters here, starting with one of our residents, Dr. Bertha Kaweo, who will be taking us through a case that represents the day. And then specifically today, we are going to be looking at respiratory physiology and as a hallmark of alteration in physiology in these patients. Remember, of course, that many other systems get affected in the patients, but we're just using respiratory physiology as one example. Then we shall have one of our fellows, our critical care fellows, Dr. Peter Waswa, taking us through the risk scoring specific to patients in critical care. And then we shall have our associate professor, Arthur Pidera, giving us the icing on the cake here, or the real cake itself, the decision-making, prognostication, or palliation in these patients. And definitely it's your choice to decide whether this is just the icing or the cake or the whole thing. But before you get to rest, we shall have Dr. Winnie Ayenyo, who is a specialist geriatrician, who will be taking us through the post-ICU care. So I'm going to retire we're going to have Dr. Kawewo sharing her slides. Dr. Kawewo is a second-year anesthesiology resident at Makerere University Department of Anesthesia and Critical Care. She will be taking us through a case summary and geriatric respiratory physiology. Over to you, Doctor. Thank you. You've got 20 minutes for the presentation, and then we shall have a conversation over 10 minutes. Thank you.
Thank you, Dr. Erasmus, for the introduction. Hope I can be heard. Good evening, everyone.
Yes, good evening. You're loud and clear.
All right, so I'm Dr. Bertha Catherine Kawewo, anesthesia and critical care resident year 2, and I shall be taking us through geriatric respiratory physiology and a case So I have no conflict of interest to declare. These are the contents of this talk. So the case is ME, an 80-year-old male with multiple chronic health issues who was under home care nursing and transferred in from another private facility with a viral pneumonia. The reason for referral was hypoxemic respiratory failure. So the patient was well until a few days to a week prior to admission, when he became lethargic and anorexic. He developed cough and fever and rigors one day prior to admission, and by the next morning, he had an increased work of breathing with sats of about 60% on room air, which prompted hospital transfer. So the chest CT done from the referring health facility showed diffuse ground glass opacities with consolidation, more on the right than the left, and a background of fibrosis and bronchiectasis. In review of other systems, he had body swelling. So his past medical history, he had multiple comorbidities. He was hypertensive with a recent echo done in March of 2022 showing a diastolic heart failure, grade 1. He had multiple myeloma on chronic chemo. He was a CKD patient, probably due to hypertension or old age or the multiple myeloma, but he was not dialysis dependent. He had adequate urine output, and the most recent creatinine done was 146, and that was done on March 2023. He also had BPH, for which TAP was done in June 2022. He had thoracolumbar degenerative spondylosis with chronic back pain. He had emphysema with bronchiectasis and on routine pneumococcal vaccination, and he had cognitive decline secondary to dementia. So that's the list of drugs that he was on. He had no drug allergies, and his 5-point frailty score was 5. He was dependent for activities of daily living, like feeding. He needed help with walking. Basically, he was globally weak. So on examination, he was sick looking with mild accessory muscle use. His BP was 161/108 with a MAP of 125, heart rate of 114, SpO2 was 89 to 92 on non-rebreather mask. He was tachypnic with a respiratory rate of 35 to 39. He had coarse crackles bilaterally, more so in the right than the left. He had better air entry in the anterior versus the posterior lung zones, and he was unable to expectorate. In the cardiovascular system, he was well perfused with a grade 2 edema. He had sinus tachycardia with occasional PVCs. He had a mild kyphosis. He was fully conscious. Pupils were equal and reactive to light, and he had no focal neurologic deficits. His abdomen was soft, and he had no mobile sounds. So that is his CBC. White cell counts was grossly normal. White cell counts were 9, with an HB of 12, with platelets of 350 and a PCT of 0.2. Liver function test, he had an elevated ALP of 257. He had an elevated GGT of 85 and an elevated total bilirubin. His creatinine was elevated, but with his baseline of 146, this was normal for him. He had an elevated urea, sodium was low, 129.6, and chloride and potassium were okay. Calcium was elevated, 3.3, magnesium and phosphate were normal. So the plan, so for his viral pneumonia, the plan was to initiate oxygen therapy and target an SpO2 of 88% and escalate as needed. He was started on steroid, dexamethasone. He was to have physiotherapy done, intermittent nebulization and mucolytics and prone positioning whenever possible. Also, the plan was to avoid invasive mechanical ventilation for as long as feasible. For the respiratory infection, since it was a viral infection, the plan was to hold antibiotics, to start him on paracetamol for the fevers, and start him on antivirals. Was also to have a COVID PCR done, which turned out to be negative. Also have influenza PCR done and a sputum analysis as soon as he was able to expectorate, and also do blood cultures. For the edema, since he was already on torsemide, the plan was to increase the dose and to continue his antihypertensive drugs, do the usual ICU housekeeping, that's fast hugs BIDP, and due to his poor clinical baseline and possible frailty to CPR in case it got to that level. The plan was to counsel the family for a DNR. So in the next 24 hours, the patient had increasing oxygen demands in order to maintain SATs above 88%. And so for that, he was started on NIV with an FiO2 of 40 to 50%, with a PEEP of 5 to 10 and a pressure support of 5 to 7. The patient also developed AFib with hypertension. And the plan was to start him on a calcium channel blocker, that's diltiazem and ivabradine to cardiovert. The patient also developed delirium and agitation. For that, he was given Dexmed, and that was also to help with the hypertension. He also had no bowel movements 24 hours later. The next day, the patient had worsening confusion and agitation, and a decision was made to intubate the patient. So during preparation for intubation, the patient vomited dark, foul-smelling contents. His blood pressure dropped and his SATs dropped, and patient got a cardiac arrest. The cardiac arrest rhythm was a PEA and then an asystole. Despite the previous decision not to resuscitate, the team decided to do CPR, and ROSC was not achieved after 20 minutes of CPR. May his soul rest in peace. So, getting straight into the
Dr. Batha, maybe just for a moment, let's just see if people might have questions for the case presentation before we proceed.
Oh, okay. All right.
All right. So, do you have any questions? Be able to raise your hand or just text your question to the chat as we proceed. Any burning questions right now? Okay, so there is a question on the chat saying if there's a DNR order already in place, why do CPR in the first place? Okay, so that's one good question. We shall keep taking more. Okay, so perhaps Dr. Batha, would you like to respond to that particular question?
Yes, so the doctor, yeah, sorry?
Please proceed.
Yes, so the doctor on duty at that time was not aware that a DNR was signed. So they went ahead and started doing CPR and only found out later on that the family had signed a DNR. So that's why they decided to do CPR.
All right, so a second question, Dr. Kawewa, is what does P stand for in the acronym versus PID? P.
The P is psychosocial support, which you want to give to the family of patients in ICU. So you not only treat the patient, but also the family psychologically. You need to prepare them for possible outcomes of their patient who is in ICU. Yeah.
All right, excellent. So just without holding us back any further, kindly proceed with your talk. If you have any further questions, kindly post them on the group so that we can proceed with answering them later on. Thank you.
Yes. So I think Dr. Erasmus gave a good preamble as to why we need to know the respiratory changes that happen with aging. So the lungs mature by the age of 20 to 25 years, and thereafter aging is associated with progressive decline of lung function. So an understanding of the normal aging related changes on the respiratory system is paramount, so that you're able to differentiate what is normal from what is pathological, since a lot of the time these changes that happen with aging sort of mimic what we see with common conditions like COPD. So these physiological changes, as we shall see, tend to predispose the geriatric population to respiratory disease, and studies have shown that respiratory disease is the leading cause of morbidity and mortality in the geriatric population. So we need to keep this at the back of our minds. So changes that happen with aging, first is changes in the chest wall. So there's a decrease in the compliance of the chest wall, and this is as a result of the age-related osteoporosis, which is going to result in a reduction in the height of the thoracic vertebrae, and is also going to cause a kyphosis. So this will reduce your anterior posterior diameter of the chest wall. And then you have stiffness happening of the thoracic cage due to calcification of your cartilages. So these changes are going to cause a reduction in the ability of the thoracic cage to expand during inspiration. When it comes to the muscles of respiration, there's an overall global reduction in the bulk and the strength. The diaphragm, being the main muscle of respiration, atrophies with age. And there's also a reduction in the fast twitch type 2 muscle fibers, which are built for strong, powerful bursts of energy. So a decline in its strength is going to predispose the elderly to diaphragmatic fatigue and ventilatory failure, especially when they have an increased ventilatory load on the respiratory system. For example, if they get a pneumonia or if they have heart disease and are in heart failure. So their diaphragm will tend to fatigue quite easily. Also, the chest remodeling is going to cause the diaphragm to flatten, and that is going to reduce its efficiency in excursion. So the effect of that is going to be a reduced diaphragmatic strength, which if you have to intubate this patient is going to make weaning them off invasive mechanical ventilation difficult. So as much as possible, you want to prevent getting to that stage if you can, if it is feasible. Then cough. The cough is less vigorous, again, since you have a reduction in the overall strength of the respiratory muscles. So the effect of that is you're going to have clearing of the secretions difficult, and this is going to predispose them to aspiration and pneumonias. For the alveoli and the alveolar ducts, those tend to enlarge with age, and that is because you have a loss of the elastic tissue and you have alterations in the supporting network of the collagen fibers. You have a loss of the collagen as you age, and the effect of that is a decrease in the lung recoil, and this is going to result in a reduction in the expiratory airflow. The recoil is important in helping with expiratory airflow. And so this is going to cause a lung hyperinflation, and this is what gives us the senile emphysema. Yes. So since you have a senile emphysema, you're going to have an increase in the lung compliance, and it's going to cause you to have an increase in the residual volume, which is the volume of air that is left in the alveoli after a forceful expiration. Basically, the volume of air that keeps your alveoli open. So that residual volume is going to increase due to quote unquote air trapping that happens. Then the senile emphysema is going to cause a reduction in the surface area for gaseous exchange and an increase in the anatomical dead space. So as a result of that, both the emphysema and also a background reduction in the respiratory muscle strength, you're going to have a reduction in your FEV1, which is the forced expiratory volume in 1 second. Then you're also going to have a VQ mismatch. So since we've lost our supporting structures, that is a collagen, you're going to have the airways in the dependent portions of the lung tend to collapse easily. And as a result of their collapse, they're going to stent the perialveoli vessels to open. So you're going to have good perfusion in these areas, but they're going to be collapsed. So this is going to cause you to have a VQ mismatch. So due to this VQ mismatch, you're going to have a decline in your partial pressure of arterial oxygen. However, you're going to have a normal partial pressure of alveolar oxygen since you have an increase in the dead space. So with that, you're going to have an increase in your AA gradient. So keeping that in mind, these patients, the geriatric patients, are going to have a low partial pressure of arterial oxygen and SpO2 at their baseline. So when you see it, don't think that they might not be having an infection. It would just be their baseline normal. So surfactant, the composition is also changed with aging. There tends to be an increase in the pro-inflammatory proteins and a reduction in the anti-inflammatory profile. And it is postulated that that's possibly because of prolonged environmental exposure to antigens that happens with time. So the effect of this is going to be an increased predisposition to infections in the elderly. So with keeping in mind that you have an increase in the pro-inflammatory changes and you have atelectasis and acinial emphysema, the elderly are going to have a reduction in their diffusion capacity. Then the mucociliary clearance is going to slow down with age and also becomes less effective with age. And in case they get an infection, especially a viral infection, the recovery of their mucociliary apparatus is slowed. So with that, they're going to have reduced clearance of inhaled particles. So since they have more like a retainment of these inhaled particles, that tends to disrupt the lung microbiome and cause bronchitis, which can become chronic and will correlate to your reduced FEV1. Then their response to hypoxemia and hypercapnia tends to reduce with age, and that is thought to be as a result of deconditioning of the respiratory drive to the respiratory muscles. So they're at higher risk of respiratory failure. Then their pulmonary function. So since they have an increased residual volume, like we say, they have acinial emphysema, they're going to have an increased FRC. So FRC is a sum of your ERV, your expiratory reserve volume, and your residual volume. So expiratory reserve volume is the volume of air that you expire with maximal expiration. But since they have weakness of their respiratory muscles, they're unable to give a good ERV with age. That tends to decrease with age. And then with a background of acinial emphysema, your residual volume is going to increase. So with aging, you have an increase in your FRC. Then your vital capacity, their vital capacity is going to decrease with age. And that is because of the reduced expiratory reserve volume. And also their inspiratory capacity is going to reduce with age, still because you have a global weakness of their respiratory muscles. Their total lung capacity does not change much with age, and that is because despite the fact that you have a reduction in your vital capacity, the increase in the FRC tends to balance that out or cancel it out such that you have not much change in your total lung capacity. Sorry, in their total lung capacity. So the take-home message, morbidity and mortality from respiratory diseases tends to increase with age. They're more predisposed to respiratory disease because of the physiological changes that happen with age. So with that, the CDC recommends that patients aged 65 years and above should have routine pneumococcal vaccination done. Then these patients are not easy to wean off invasive mechanical ventilation. So it should be delayed as much as possible or as feasible. And if you do get to the point of invasive mechanical ventilation, it should be individualized to the patient. It's not a one glove fits all. Then routine use of bronchodilators is not recommended. Studies have shown that it is not recommended because you have a reduced beta adrenergic sensitivity to beta agonists, and that is due to reduced affinity with age. So there's really no role for them in routine use. And then steroids should be preserved. Well, we know that there's a background pro-inflammatory change that happens with age. However, the steroids should be reserved for respiratory failure or ARDS and should be avoided in case there's an underlying fungal infection or TB. Those are my references. Thank you. Back to you, Dr. Erasmus.
Excellent talk, Dr. Batha. Thank you very much for covering this in such a short time. So quickly, we have some questions. Let's start with, okay, we've answered the issue of the P in the first service BID. Then we've got, okay, it's a comment from Dr. Timothy Muimbo. Timothy Muimbo is an anesthesiologist and intensivist. And he suggests that intubations are better than electively, which we should, and we should improve our decision on when to intubate if patients are most likely not improving from other interventions. I will take this on. So thank you. This is very correct. And definitely once you have a clear indication that a patient should be intubated, perhaps go ahead and do it. Now, this patient unfortunately had, or fortunately had a kind of at the beginning, a very clear kind of direction of care. This is a patient who was in for a limited ICU admission given his baseline frailty and chronic health issues. So the idea was hopefully turning around his acute respiratory illness with the hope that he would not necessarily require any aggressive, invasive interventions. And that is really why we had to try to maximize, in this case, the care with non-invasive means. Unfortunately, at the point when the patient was getting kind of uncomfortable, restless, and becoming less compliant with the non-invasive means, there was definitely that conversation again. There's always a change of mind with family and the like, where they felt maybe we can just proceed and intubate. But sadly, this is kind of one of those bad cases where you're on shift in the middle of the night and somehow you're now preparing to do the intubation. The patient still seems to be comfortable, but suddenly just crashes. And it's kind of a unique case here where the patient has one of those closing conversations with the family, tells them, oh, take care of my wheels, or watch out for my wheels, and so on, and then suddenly just, arrests. So I definitely agree with the comment, and we should definitely always aim for that. And if you're in doubt about what you want to do for the patient, just proceed and intubate, because the most secure thing to do. But more importantly, always consider individualization, like Dr. Batha said. Then Dr. Batha, there's a question, wouldn't a blood gas test be a point of care investigation to get a global view of the respiratory status of the patient? What do you think?
Yes, I think it's one of those things that would help guide your therapy. Yes, I think it would be a good one to have.
All right, so while this patient was on about 8 liters of oxygen, 5 to 8 liters of oxygen, a blood gas was taken off from him and is posted in the chat. Basically, he had respiratory alkalosis. His pH was 7.59, his CO2 was 25, PO2 was 192, and the bicarb was 23. So in regular respiratory alkalosis, what would you expect the bicarbonate to be, Dr. Bat?
Sorry, Dr. Asbas, could you repeat the question?
In a patient with acute respiratory alkalosis, what would you expect the bicarb to be?
It would be increased. Sorry, it would be low.
Okay, so what do you make of that bicarbonate of this patient?
Let me look at it. Sorry, I wasn't looking at the chart.
Okay, so the pH is 7.59, the PCO2 is 25, PO2 is 192, and the bicarb is 23.
Could you repeat that? Sorry.
Can you look at the chart? I posted the ABG there. It is pH 7.59.
Oh, okay.
PCO2 25, PO2 is 192, and bicarb is 23. What would that tell you about the patient respiratory physiology at baseline? I missed including the saturation. 99. Yeah, the bicarb is 23. So anyway, I guess overall what we're trying to say is that patient's bicarbonate is far too close to normal for a patient who's having an acute respiratory alkalosis. So it probably suggests that at baseline chronically, the patient is retaining bicarbonate, which is consistent with the patient's baseline chronic history of COPD. That's just what it would highlight. So that means that you're not starting with normal physiology in this patient. Whatever appears to be normal there may just be an acute derangement for him. Okay. So the other question is on ivabradine. Ivabradine was given to this patient and was his chronic medication for his heart. Were we using for pharmacological chemical cardioversion? That's the question from Dr. Oyang.
Yes, we can.
Okay, so anyway, so this ivabradine is one of those energy safe drugs that has recently come into the market, maybe now about 7 or so years in the market. It works by impairing the IF current, that rectifier current, that kind of helps pacemakers regain their baseline, and then they trigger to the pacemaker activity. So by slowing that down, they safely reduce the heart rate without consuming energy. So it's good for patients who've got quite a weak heart, sick heart, among other things. So it's in this patient, it's not very clear why his cardiologist specific went for this chronically for his heart rate management in CHF, in heart failure. Incidentally, his echo previously has shown hypertensive heart disease. So the ivabradine seems to have been put in there for rate control in a setting that has got COPD and may not necessarily be compliant or tolerant to beta blockers. At the same time, he also had a calcium channel blocker, diltiazem, which was serving two functions: heart rate management as well as blood pressure control. I suspect that they put the two together because one, they like and know the drugs, and two is that they could not go much higher with the diltiazem because maybe the patient getting hypotensive, and so they wanted something else to on top of that for heart rate control. But yeah, using ivabradine for chemical cardioversion might be a little bit of a stretch. It probably doesn't do that role that it's had that function for it, Dr. Oyang. Okay, then the other question, final question, please. And the other question, should answer them on the chat. How easy was it to get DNR from the relative given societal beliefs? That's Dr. Winnie. Dr. Kawewo, do you have an idea?
So since I didn't participate in the management of the patient, maybe you can tell us, Dr. Erasmus?
Okay, yeah. So I guess the patient, first of all, the patient is from a very highly educated family. The patient himself being quite a highly educated man, professor, and so it probably means that there was quite a lot of thinking around this. And while they are not had a conversation, it looks like the thought was there before. So once they presented with the facts about the physiology of the patient, given chronic health, given the age, given the baseline frailty, among other things, it was quite easy for them to accept that they may not see their dad go through very painful, aggressive interventions in the ICU, and much so in a situation where he might get cardiac arrest with less chances of reversal, but also a lot of morbidity post resuscitation. So it kind of made it easy to get a DNR out of them. So yeah, but yes, I agree. In our highly religious and culturally tightly corseted communities, a bit difficult to get such orders. But one thing that every doctor needs to remember is that DNR or goals of care is a joint decision-making process between the physicians and the family. It's not a one-way thing where you leave it to the family to decide what they want. It is you to guide them to understand the full detail of what exactly lies ahead of them and their patient, and whether the care you have can actually achieve some of the superfluous, exciting goals that they have in the company hospital. And when it's clear that they can't meet those goals, it's unlikely that anyone will want to go with CPR. All right, thank you very much, Dr. Batha. And in the interest of time, I would like us to proceed to the next talk. We shall answer some of the questions on the chat, so keep them coming. Our next speaker is Dr. Peter Waswa. Dr. Peter Waswa is an anesthesiologist, and he's a fellow with a critical care program, the SCALE program. And he will be taking us through the risk scoring specific to geriatrics in critical care. Dr. Peter Waswa, kindly share your slides. Dr. Peter Waswa.
Yes, Dr. Erasmus, let me share.
Thank you, sir. All right, kindly keep your questions coming. We shall be answering them in the background. Thank you.
Good evening, everyone. Hope you can hear me. So I'm Peter Wasso, and I'm going to be taking us through risk scoring specific to geriatrics in critical care. So maybe some few things to put at the back of our minds. So 5.4% of our population is actually above 60 years. So based on Uganda Bureau of Statistics, an elderly person is actually one who's above 60 years. And then 2 of every 10 households have at least one person who's above 60 years. Life expectancy for Uganda's of 2019-2020 report stays at 63.7 years. And then that's what corresponds to males versus females. And then about 73% of our population stays in rural areas. When they try to assess these patients that are above 60 years, 5.6% had diabetes, 19.9% had hypertension, 5.1% had heart disease, and 24.1% of the whole 5.4% had at least any of these 3 conditions. Those were the commonest comorbidities in them. And then for all cause mortality in the whole population, malaria and pneumonia were the leading causes of death. So pneumonia is important for the elderly population. So with aging, people have some things that they are predisposed to, what they call the geriatric syndromes. And when you get a geriatric patient, some of the things that you're going to be interested in assessing for, those that are major things like the functional capacity, risk for falls, cognition, and others that are minor, which may not apply to all. Things like nutrition status, urinary incontinence, and sexual function. So when talk about functional status, we are interested in the ability of this individual to perform activities that are necessary or desirable in their daily life. So this is going to be influenced by the health status of the patient. And then also the functional status of your patient is going to determine the outcomes of your patient post-ICU. So when we talk about functional status, we basically divide it into 3. We assess in terms of the activities of daily living. So in the geriatric population, we have basic activities of daily living like bathing, dressing, and feeding. We have the instrument activities like, say, being able to drive a car, being able to, or using public means like a taxi, being able to use our telephone, or doing laundry for yourself. And then there are those that are advanced, like, say, you're able to use a smartphone, you're able to use internet, or you have a specific schedule of activities that you do daily. So from basic to advanced determines the outcomes of your patient post-ICU discharge. So when you get patients in ICU, ideally, the functional status is supposed to be based on the activity of your patient about 2 weeks before their admission in your critical care unit. So these different 3 basic, instrument, and advanced are assessed using different tools. So for basic activities of daily living, the tool that's usually used is the CALS Index of Independence in Activities, whereby you're going to be assessing a given activity and you give a score of 1 for the patient is able to do these things for themselves, or 0 if they're not able. So the more the points a patient scores, the more independent the patient is. The less the points a patient scores, the less independent your patient is, and the more they need to be supported. When it comes to the instrumental activities of daily living, we use the Lawton scale. So you ask questions, for example, is the patient able to use a telephone? And then you give points based on the responses they give you. Still, the more the points the patient gets, the more independent they are, and the less the points, the less they are able to perform the instrumental activities of daily living. When it comes to the advanced activities of daily living, you're going to assess them by asking open-ended questions because they are a bit complex. So we're not able to assess them based on such a scale. So the Canadian Medical Journal assessed the outcome of patients, elderly patients. These were patients that were above 65 years that had been admitted in ICUs in relation to their baseline functionality. And as you can see, patients that were independent with their basic activities and instrumental activities of daily living, after a minor illness like say a UTI, their functionality drops a bit, but within a short time, they're able to go back to the baseline. Whereas patients that needed help with instrumental activities of daily living, the functionality significantly dropped and took a longer time to go back to the baseline. And those that had that needed help with basic activities of daily living, it even took a much longer time for them to go back to their baseline. And then those that had a major illness, for example, needing ICU admission, if a patient was able to do for themselves basic activities of daily living and instrumental ones, within 6 months post ICU discharge, they were able to kind of go back to their baseline. Whereas patients that needed help in instrumental activities of daily living were not able actually to go back to their baseline, and those that needed assistance in the basic activities of daily living actually never even returned to baseline. So the functional status of your patient in ICU is going to play a big role in the outcomes of your patient after discharge from ICU. Then the other scale that we use for patient during the introduction, Dr. Rasmus was able to let us know that with the advancement in age, you're going to have a decline in your physiological reserve, you're going to have a decline in your energy reserves, and then you're going to be being actually more frail. So we assess for frailty in the elderly using the clinical frailty score. What should be noted is being frail is not directly related to someone's age, but it's independent associated with a higher risk of dying. So the higher the score, the more the chances of you not leaving ICU, or the more the chances of you not being able to make it within the first 6 months after ICU discharge. So this prevalence that was quoted is actually not for a Ugandan study. It's for a study in Canada, whereby the incidence was about 30% for all patients that were admitted above 65 years. So the score has 9 points. And as you can see, point 1, that's an elderly patient who's fit, they're able to do some activity, most of the activities for themselves. And the higher the score, the more the patient is actually not able to do anything for themselves, and the more they are likely to end up with bad outcomes within the first 6 months after discharge from ICU. So how does stress and frailty affect an elderly? So if you look at these images, so this is a patient who is fit, and this is a patient who is frail. So what you can notice is with acute stress, the risk of death for a patient who is frail is actually much more raised than a patient who's actually fit. The patient who's fit, the risk is almost not that significant. If you can see how the change is from the baseline. So the more frail, the more you're likely to die following an acute illness. So the other thing that comes with advancement in age, one of the syndromes is delirium. So most of the patients that, a number of patients that are advanced in age end up with things like dementia, and then some actually end up with the acute confusional states. So the most important thing in these patients is to not manage them pharmacologically, but to fix what has caused the delirium. So some of the risk factors for these patients are use of benzodiazepines, which is the only modifiable risk factor among these. And then advancement in age is not modified, having history of dementia, if someone had been in coma before, and then if they had emergency surgery or trauma. So we assess for delirium in ICU for these patients advanced in age in two ways. You can use the configuration assessment for ICU, which is more specific but less sensitive, which means you're most likely not going to miss out a patient with delirium. Or you can use the intensive care delirium screening checklist. It is more sensitive, which means it may even pick failures that are not your typical delirium, but it is less specific. So in the CAM ICU, you're basically going to be asking questions that are going to be leading you to making a diagnosis. For example, has the patient an acute change in the course of their mental status? If there is, it has not happened, then the patient does not have delirium. In case it happens, you continue down the flow chart. Then the intensive care delirium score, the intensive care delirium scale has about 9 points, and each point a patient scores enables you to come up with whether they are having delirium or not. So the more the points they score, the more they're likely to be delirious. So it is advisable to be making these scores on a daily, so that you assess how the patient is going to be progressing during the course of stay. And then the other thing that is common in patients that advanced in age is malnutrition, because most of them may not want to eat. So, which can be assessed using the malnutrition universal screening tool. So it has a few steps that you do. So you're going to take the body mass index of your patient, and they're going to give a score. The more the score of 0 to 2, the higher the score, the more likely the patient is malnourished. And then you're going to find out if they've lost weight within the past 3 to 6 months. If they've lost over 5 to 10%, that's a score of 1. If they've less than 5%, that's a score of 0. And then if the patient is actually acutely ill within the last 5 days, which will give a score of 2. So based on the score, the patient is going to be either low risk, medium risk, or high risk. And then you institute the plan as needed. Thank you. Those are my references.
Excellent, excellent. Thank you so much, Dr. Waswa. They say the best, chef is the one who serves food so good that when you say like it, it runs out of your plate, and when you say want it, and so you're left salivating. So thank you so much. This is nice. And yes, we are just time bad, but it's something that we'd love to listen to a lot more help us bedside. So quick one, people, do we have any questions for Dr. Waswa? For those who like to ask directly, kindly, and raise your hand and they shall choose you. And for the rest, you can see type on the chat. I shall receive it. So maybe Dr. Waswa, okay, Dr. Cornelius, kindly ask a question. Thank you.
Yeah, thank you so much, Peter, also for that wonderful presentation. Mine is going to be a fairly tricky question that may not have a straightforward answer. But considering that 75% of Uganda's population is under 15 years, or 50% rather under 15 years, and 75% is about under 30 years. And with the extreme ICU bed capacity limitation per population, that means all the previous studies have shown 1 to 1 million. What would be, and then of course, everything that you've told us about the potential high risk of mortality as well as morbidity among the elderly patients. What then would be your opinion or your perspective on a geriatric patient getting admitted into an ICU that is, say, publicly funded and not necessarily privately funded? Should there be some form of triage? And if there's some form of triage, how should that be categorized based on your risk scores? And in other words, how can someone make a decision for a patient like this one in a publicly funded ICU? Private is different because that's a different ballgame, but publicly funded means that the resources are coming in from the masses, and so there can be some ethical challenges there, especially if you have a huge load of younger, potentially survivable patients who may also be competing for the same bed that is scarce. So I hope my question is clear to you, but just a perspective on that. It's definitely not an easy question to answer, I realize, and it has a lot of complexity around it. But your opinion is still valuable to me based on what you presented.
Go ahead.
Okay, thank you, Dr. Cornelius, for that question. So ideally, I think I would be guided by the ethical principles for the institution. Let me say I'm having a 60-year-old. Let me say 85-year-old and a 27-year-old, and they all need the IC space. I'm having one bed, so I'll basically involve a number of people to make the decision. Before I wouldn't make the decision solo. So I'll discuss with the superiors, those are ahead of me, the supervisors, and then we decide based on a risk, based on who's going to utilize the bed much more than the other. And then maybe also advocating for more ICU beds.
All right, thank you, Dr. Peter Waswa. Perhaps Dr. Cornelius, on top of Dr. Waswa's take on your question, the next talk actually tackles the decision-making process regarding this. So Dr. Arthur Kwizera, who will be our next speaker, please kindly take note of this question because she'll rebound it for you. The difficult question of who gets a bed and who doesn't, whom we let die and whom we try to save, given limited resources and a public funded care. Thank you. So Dr. Michael Rahire, an ICU nurse, quite a talented friend of mine, is asking on the chat, can we incorporate these charts or tools in our protocols of assessment and management? They seem rare to many of us. Is it because our focus previous has been on elderly care, especially in critical, hasn't been on elderly care, especially in critical care? Dr. Peter Wassa, what do you say about that?
About the incorporation of these charts in our critical care, it would actually be a good thing. But it goes back to policymakers. And then also, most of the population of patients we get in our ICUs are actually usually young people. But I think it would be a nice thing to have them incorporated in our tools, that because ideally they don't require much for them to be used.
All right, so at least I've seen like the CAM-ICU test is there. The frailty scores, some charts may have them, but again, these are really individual physician decision-making tools that ideally supposed to be used to guide the overall care the patient gets, and hopefully, the challenge, the idea is really to make sure that you are not distracting the team with a lot of clerical work. The bedside nurse, the bedside physician is really focused on care of the patient. And some of these are really important for decision-making that guides ongoing care, but also decision-making that leads to which direction of care is going to be adopted. So perhaps we shall get more clarity when Dr. Arthur presents. But before we call Dr. Arthur, let's get a question from Dr. Timothy Moyimbo. Kindly unmute and speak, Doctor.
Yes, thank you, Dr. Erasmus and Waswa for the presentation. Mine is just an additional comment to what Dr. Cornelius raised. It is a very pertinent issue. Recently, I attended a webinar, I think it was a CME by the pathology postmortem, and they presented a similar case, a 78-year-old who presented with respiratory symptoms, and then they decided to go down one line of thinking it is TB, but because of the restrictions in diagnostics in Mulago, and then probably also the facilities requiring maybe higher care, and I think the ethical dilemma of should we even consult the ICU team for a 78-year-old who supposedly looks like they're doing badly when we have younger patients and maybe we don't have ICU and the facilities. So eventually the patient worsened, but from the presentation, the patient outrightly looked like a person with sepsis and SARS, which they did not manage. They were grappling about how they are going to make a diagnosis of TB. So on postmortem, when they dissected the lung, they found a Klebsiella pneumoniae there. So patient also had a suprabacterial infection, Klebsiella with the pus, all the thing, and from the start was septic. So I think we can do the most good with the little we have. The most important thing, it has been presented very, very well that their physiology is deranged, they have reduced reserves. These are patients whom you will suspect, even with a slight tip over, they will go. So what do? You go ahead of them, make preparations, don't wait for them to worsen. So I was thinking that maybe as the ICU team, critical care team, we can educate, inform the wards, the other departments of the danger signs of the reduced reserve, and then when to call. So when you are called early, you can institute not necessarily ICU, but even HDU care, because if that patient had been stabilized following the sepsis bundle, the 1-hour bundle, these people had not even thought of this thing, a culture before antibiotics. They had not done appropriate antibiotics. They were giving gentamicin, ceftriaxone. Are you seeing? The thing came out, eventually it was carbapenem sensitive. Meropenem would have saved this patient. So I think early response and institution of some of HDU care can save many of these patients. And on the wards, you can institute some level of HDU care so that the patients are got early and they don't deteriorate. Thank you.
Excellent comment. Thank you very much. And it's again a case of the eye knows, the eye sees what it knows, or I don't know how they usually, how that metaphor is, but basically what people are familiar with, what are likely to suspect all the time. And if you, by some mistake, end up in a triage such a department, people are likely to treat what they know or such what they know. All right, so without further ado, let's invite Associate Professor Arthur Kwizera, the first of his kind in our department, in anesthesia. Dr. Arthur Kwizera, kindly share your slides. So Dr. Arthur Kwizera is an associate professor at the Department of Anesthesia and Critical Care. His passion is in critical care medicine. Also loves issues of systems improvement in terms of general care across the country. He's doing a lot of projects. He recently completed his PhD. The man has done so many things. But I don't have a lot of time to read this whole CV because it might consume the rest of the time. Dr. Arthur Kwizera, are you on the chat? Okay, so Dr. Arthur is yet to join back. He's supposed to take us through decision-making processes in the geriatric population in the ICU, and we shall get to him once he's able to join us. As in the interest of time, I guess we shall proceed to the next speaker, and then we shall get back here. So Dr. Winnie Ayenyo. Dr. Winnie Ayenyo is a family physician with a subspecialty training in geriatric medicine. We see patients a lot who are critically ill, who are cared for in the ICU. We deal with acute care, and we hope to get them out of ICU when they get better. And when they get better, unfortunately, we don't have the tools, the experience, the knowledge in some corners of our country, and resource definitely to take care of these patients. So Dr. Winnie Ayenyo, with a background in geriatric medicine, will be of great help to us this evening. She will take us through post-ICU care of the geriatric patient. Dr. Winnie Ayenyo, take it away. Thank you.
Thank you, Dr. Erasmus. Am I audible?
Yes, we can hear you loud and clear.
Thank you. All right. So like Erasmus introduced me, I'm Dr. Winfred Ayenyo. I sit at Naguru, China, Uganda Friendship Hospital, and occasionally at the surgery in Naguru. So I'm going to take us through the post-ICU geriatric care. Now, this is a continuation of care from ICU, but using the basic principles of geriatrics. So in this care, our aim is 1, to optimize physical capability or capacity. 2, we want to reduce the overall length of hospital stay for the patient. Also, we want to observe the family or the patient care goals. That is what we mean when we talk about advanced care plan. It was mentioned as Dr. Batha was giving the history about the patient. She said that the patient had a DNR. Now that is part of the advanced care plan. And as we care for these patients, we need to continuously review what the family and the patient wish for their care plan. That's very important. The geriatrics principles that are involved in this post-ICU care include the age-related physiologic and pathological changes. So we see that as we age, there are some changes that happen, and because of these changes, there's going to be decreased physiological reserves. And as a result, as some of the patients are recovering, we shall notice that many of them go into a state called the deconditioning state, whereby there's marked decline in their functional capacity. So while you're taking care of this patient, you need to be cognizant of the fact that their functional capacity is likely to reduce. So you bring in measures that are meant to help either restore or bring them to a fairer level of functional capacity. Then we need to note that clinically, most of the geriatric patients, particularly the frail ones, will present in an atypical way. A patient might have, let's say, septicemia, and they will not necessarily have a fever. So how do we diagnose? I mean, we need a better clinical acumen to be able to tell that this patient indeed has septicemia, despite the fact that they're not having a fever. So that involves us integrating the laboratory tests, you know, and routine examination, noticing how exactly they present in the event of some of these conditions. Also, we need to be aware of the geriatric syndromes. Dr. Waswa mentioned a lot about the geriatric syndromes. So we have things like delirium. Many patients will tend to go into a delirious state, and that usually is a sign that something is wrong physiologically. So as we manage them in the post-ICU care, we need to be cognizant of that and tailor our care accordingly. Then the principle of multimorbidity. Multimorbidity is whereby you see that most of these patients usually come with more than 2 or 3 medical conditions. A case in point is a patient that was presented. They had chronic kidney disease, heart failure, you know, et cetera, et cetera. So there are usually many conditions. So we have to manage each condition in the context of the other. Then as such, we will have issues of polypharmacy. Many of these patients end up using more than 3, 4 drugs. So it's important for us, therefore, to keep reviewing these medications and see what is needed at what point. So that is important as we're caring for them in the post-ICU phase. Then quality of life is key. It's important that we aim at restoring or giving the patient the ability to carry out their normal day-to-day tasks and give them the best quality of care at the end of the day. In cases where there is frailty, we expect that the outcome might not be very good. So how do we optimize? How do we get the best outcome for this individual patient? So that is important. Aim at good quality of care, of life, sorry. Then in this care, using the geriatric principle of interdisciplinary approach, we want to make sure that we involve the various disciplines that are going to help to restore this patient back to their original, or close to their original phase of function. So that means that we will have a team of disciplines working together to ensure that the patient gets better. We have to, bring in the rehabilitative therapists like the physiotherapist, occupational therapist, a nutritionist has to be on board, a pharmacist has to be engaged, every day to ensure that, they regulate and review the medications that the patient is on. Then in the post-ICU geriatric care approach, we look at 4 things. 1, integrating those geriatric principles that we've talked about. 2, we engage the biopsychosocial approach in planning for the care in this phase. So biopsychosocial means we not only look at the biomedical aspects of the disease, but we also look at the psychological and the social aspects that are involved in this older patient who is in the post-ICU care. So we must consider to a great extent the family of the patient, the state of the patient, who are these people in, in regards to their roles in the family, and how do we bring in all that general, the comprehensive approach in caring for this patient. Then 3, we want to do the routine geriatric assessment using the tools that Dr. Waswa elaborated on clearly. So he talked about tools like, the frail scores, the CATS ADL, the Lawton, instrumental activity of daily living scores, the ICU delirium screening checklist. That is important. So as a geriatrician, we usually encourage that as we are assessing these patients on a day-to-day basis, we need to continuously score them and see where the patient is and bring in those that we need to help improve the patient status. Then it's important that we mitigate the post-intensive care syndrome. So we're going to look further at this particular syndrome and what it is about. So the post-intensive care syndrome, this encompasses a series of symptoms of new or worsening cognitive, physical, or mental health impairments. Already the patient has health issues, but we believe that when you take most of the elderly patients or the seniors to an ICU, there's a chance that they're going to get worse, or they're going to get new changes in as far as their physical, mental, and cognition is concerned. So it's important to note that there will usually be a post-ICU syndrome. And it's known to affect the patient and even the family. So we all know, probably we have all experienced that when a patient is in ICU, usually it takes a toll on the family members as well. So in this care, in this post-ICU care, we want to involve, managing both the patient and the family alongside. Then literature has it that it affects between 25 to 55% of most of these senior ICU survivors. So this is significant. Then it includes symptoms like the post-traumatic stress disorder, impairment in activities of daily living, depression, and cognitive impairment. This syndrome may persist right from ICU, post-ICU, even up to discharge of the patient from hospital. So that is why in certain settings where they have geriatric-friendly services, they will usually dedicate a fully fledged unit for geriatric rehabilitation. The reason for these units is such that we overcome some of these syndromes like the post-intensive care syndrome. So in this syndrome, there are components which involve the cognitive, the mental health, the physical, and the family or environmental components. So under cognitive impairment, there might be global cognitive, reduction in global cognitive function, executive function, memory and attention decrease. Then under mental health, we commonly see things like depression, PTSD, anxiety. Then in the physical impairments, we might notice some muscle wasting, weakness, decreased mobility, pain, fatigue, shortness of breath, just as we've seen in the respiratory ailments, and reduced appetite. Then for the family and the environmental factors, we will see, patients, family members going through complicated grief and many other issues involving the family. So this is a combination of the components that we will see in this syndrome. Now, how do we manage each of these components? One, under cognition, we usually recommend that to manage the cognitive aspect, you need to encourage the cognitive stimulation exercises. For example, the time reminders. You have to continuously speak to your patient, remind them that, oh, today is the 12th of May. This is, we're at 6 p.m. We are in this hospital, yeah? Then you can play for the patient's music if it's acceptable in the facility. Then we encourage that the family members, the close family members, keep speaking to the patient to bring in the voice, the family voice reorientation. That helps to improve cognition of such a patient. Then when you look at delirium, we recommend using the ABCDEF bundles right from ICU. And under this bundle, it's a bundle that we use to manage delirium. The A stands for assessing, preventing, and managing pain appropriately. Then the B involves encouraging spontaneous breathing trials, spontaneous awakening. The C is you be cognizant of the choice of analgesia and sedatives that you're using. So you can go through the ABCDEF bundles to see how we manage, how we use this to mitigate delirium. Also, we encourage that we minimize the use of restraints and tethers for most of these patients, actually for all of the patients if possible and where possible. This helps to prevent delirium. Then for the sleep, we encourage that the patient sleeps in a comfortable environment with less noise. So if it's possible, where it's possible, get them earplugs. So we can convert the daytime bolus feeds to decrease the nighttime interruptions. So what you do is you make sure you give more frequent daytime feeds rather than waking up a patient and interrupting their sleep. That could also predispose to things like cognitive impairment or decline. Under mental health, we usually see mood changes, and we recommend that we continuously keep screening for depressive symptoms in the patients using the tools that we saw when Dr. Waswa was presenting. Then when you find that the patient is depressed, then you have to bring in a psychotherapist to support this patient during this phase. Under physical health, the functional capacity, yes, we encourage early physiotherapy or occupational therapy assessments. This is to help us plan for what the patient will need even when they are discharged from the facility. Nutrition aspect is very important. So involving a dietitian, having them, consulting them to guide us on what the patient needs is very, very key during this phase. Under continence, we want to make sure that we remove indwelling catheters as soon as needed. This is important because firstly, we shall be reducing bladder infections, but also reducing on the risk of delirium. Then we want to promote mobility as soon as possible. So it's important that you get the physiotherapist to support the patient to move. For skin integrity, we all know that when you spend a longer time in bed, you are likely to get bed sores. Yeah, so it's important that we frequently turn these patients in bed. For polypharmacy, the pharmacist is very key here to do a daily review of medication. And we can use the stop-start criteria, or we can use the American Geriatric Society BIAS criteria. Now, this criteria reviews the medication that the patient is on, and then you're able to adjust according to the dose that the patient needs. You're able to know which medications are, high risk, which ones should we change, which ones should we cut out. So it's important that you use this BIAS criteria on a daily basis to review the medications that the patient will need. In the domain of environment, we do environmental modifications during the post-ICU care phase. And it involves using clocks, particularly the large clocks. They're good for time reorientation of the patient. You can put a calendar for the patient or remind them of what the date is. Then we advise that in a hospital setting, ideally, it should be tailored to, take care of this older patient. So it should have handrails, it should have cluttered highways to allow, easy and flexible mobilization. Also, we want to make sure that the restrooms are suitable for these elder patients. We want to have, colors that emphasize on earth tones, with contrast between the floor, the wall, the ceiling. This aids the patients with impaired depth perception. So ideally, all this is to help us mitigate delirium. Then for the family, yes, like I said, we need to continue to review the care goals of the patient with the family as well. We need to involve a psychotherapist if needed. We need to involve the aid of a social worker. Most of our hospitals actually have social workers, and sometimes we wonder, what do these officers do? But yes, we can involve them in this post-ICU care as well. So overall, we want to bring in this multidisciplinary team, but with an emphasis of the patient returning home or to their pre-hospital living environment as soon as possible. That is very important. Now, in summary of this care, 1, we want to observe the family and patient care goals. 2, we want to integrate the geriatric principles into this post-ICU care. Then we want to continuously do a geriatric assessment to be able to gauge where the patient is, what more aid the patient needs. Yeah. Also, we want to make a discharge plan, but with the intention of having an early return at home or to the pre-hospital environment. Thank you, Dr. Erasmus. Dr. Erasmus?
Yes, doctor.
Yes,
excellent.
that is the end of my presentation. Thank you.
It's so unfair you're stopping now. So unfair. But thank you. This is an excellent talk. And will be beautiful. Again, I guess today has been just one of those days where, like Neil, every talk is as great as the previous, and you just want to keep listening. This is a topic that would be of great help to all of us as practitioners in critical care, and it's an eye opener too, especially that I think the geriatrician population is increasing too. The geriatrician population now, to the best of my knowledge, it's like there are 2 people now who have taken on this particular area. Perhaps one day we should come up with geriatric critical care as a subspecialty of critical care, and have you guys just come in and sit with us and do amazing work with this elderly population. Again, our population is increasing in age, and people are surviving longer, and so we're going to see more and more of these people in ICU. And the conundrums Dr. Cornelius and Dr. Timothy alluded to earlier on are going to be major issues to deal with when the time comes. Or we're already dealing with them. I would say during COVID, we actually dealt with such difficult times. So Dr. Winfred, thank you for your talk. We would like to welcome questions from the team, but perhaps Perhaps I will reflect the question where I plan to direct to their speakers, to you as well. If you had a 28-year-old person critically ill, requiring ICU care, and you also had, let's say, 78-year-old seeking ICU care, for the same disorder. Let's take an example of COVID times. How would you approach the decision making in terms of allotting a bed for these patients? Dr. Winfred?
Thank you, Erasmus. Well, that is a very interesting question. But again, it goes back to ethics. Who are you going to consider and who are you not going to consider? If you come to me, I'll say, oh, the geriatric, the older patient. You know, if you go to an internist, they'll say maybe the younger adults, yeah? But it is also, it helps us to throw this question back to those at a policy-making level. I think we need to get to a place where we do not have to be pushed to a corner to decide who goes where. Yes, the prognosis might not look as good, but I mean, they also need a chance to life, yeah? So who do we consider, who do we not consider? So hopefully, you know, our policymakers will reach a place where we have enough space to consider even the older person. Many of us, yes, would think, yes, let's take the younger person and leave the older one. But I mean, they also need a chance to life. They also need to continue living. Yeah, so it's more of the ethics, but also pushing it to those that are in a place where they can, you know, get us out of the situation where we have to decide. We have to pick one over the other. Thank you.
Wow, interesting one. Yeah, now, of course, as you notice, first of all, the decisions to increase bed capacity, for example, will take forever. We shall be geriatric ourselves by the time anybody starts thinking about improving bed space capacity. Nonetheless, there will never be enough ICU beds. What I've seen in some other healthcare systems is a network of ICU beds across, because it's a system which is a single payer kind of situation where the beds are networked, and the absence of a bed in one hospital doesn't mean you can't get a bed in another hospital. And definitely now the principles of who's taken up first will now be applied by triage. So if the elderly patient is much sick and not expected to get better with more time before they get critical care, they may be taken up in this hospital while the younger person is probably moved to another place. But we are not yet there yet. There's definitely that promise by the politicians that they are increasing bed capacity. When we shall realize that is a different question, because especially because operationalizing them doesn't seem to be a priority. Yeah, but quite a difficult question. So Dr. Cornelius has a question for you. Dr. Cornelius asked, at what point should the intensivist involve a geriatrician in care of patients? Dr. Winnie?
Okay, thank you for that, Dr. Cornelius. Now, borrowing from the experience I had in Canada, the geriatricians were involved during the geriatric rehabilitation. That is the post-ICU care. When a patient gets out of the critical state, they are moved to a unit that is fully fledged with geriatricians, with occupational therapists, nutritionists. So usually in the post-ICU phase is when the geriatrician comes in to review the medication, to work together with the other multidisciplinary teams such that they support the care of this older patient. Thank you.
Thank you for that. What happens in situations where I would believe if we're in a fairly functional system, the geriatric patients should probably all come from a geriatrician as a referral to the ICU, and as such would be the intensivists probably be able to ping off ideas from the geriatrician, especially regarding the chronic health and some difficult situations regarding approach care. And also in that situation, I would assume that the geriatrician has a better rapport with the family and may also help in some acute care decisions, especially regarding course of care.
Yes, I'm not sure I've gotten the question right, but it's important that the geriatrician works together with other physicians. They cannot work independently. So during the care of a patient, if an internist is seeing a patient an anesthesiologist is seeing a patient, they have to work together with a geriatric specialist to help bridge that gap, you know, to help them come up with a care plan, to help them adjust medications accordingly, to review and see how far the patient is going, what the prognosis is. So I think on a daily, ideally in every internal medicine ward or adult care ward, there should be a geriatric specialist to be consulted or to be co-opted to work together. Yeah, that is the ideal.
All right, thank you. Cornelius, please unmute and ask your question, sir.
Yeah, I would just like to put my question in context for Dr. Winnie to consider. I think one of the advantages of high-income countries is that they have the opportunity to have post-ICU care settings, while in our setting we don't. So most times we may transition a patient within the ICU to a level where they're HDU level care, and that would, like in a high-income country, be somewhat consistent with the post-ICU care setting for like a rehabilitation center. So that's why my question to you is, at what point, with lack of those settings that we can transition patients to, at what point in our setting here locally would we then invite you in to come and start to transition the care of this patient to you, of course, in a scenario where you did not know about the patient?
Okay, thank you, Cornelius. So in our setting, I think the ideal would be as soon as you feel the patient is ready to be transitioned from the critical care, then you can give a call to a geriatrician to come and review, or invite the geriatrician to start off, to take on the care of the patient. So I think as soon as you're done with the critical part of the care, then the geriatrician should come in and work together with you. So it doesn't matter whether you move them to HDU, you know, for as long as you are done and you feel the patient is now at a state where the physician can come in, then they are welcome, I think, to start.
All right, thank you. Hopefully this is satisfactory also to Dr. Cornelius. We welcome more questions. Dr. Fiona, please unmute as well and ask.
Yeah, thank you very much. It's such an interesting discussion. I would give an experience. There was a patient who was 104 years old and was airlifted by the family to a private ICU facility. Needed urgent intubation, but with all the comorbidities that she had, with just an acute assessment, the family was seated down to try to help them understand the poor prognosis that the patient had. Then their comment was like, this is our mother. Like, by the time we airlift her, I mean, here we want all the care that you can give, irrespective, you know, of the outcome. So the decision making was, it was so difficult, especially to consider themselves for a non-resuscitate order and all that. Fast forward, the patient lived for a while and had to have at some point a tracheostomy placed, and probably the point was to transition them home on, say, assisted ventilation at home. I'd want to hear from the geriatrician how feasible it is to have these patients post-ICU with assisted ventilation at home, and how do they handle that? Is it with the intensivist? How is that handled?
Okay, thank you, Fiona. Now, part of the principles of geriatrics involves, one, reviewing the advanced care plan of the patient. So at that point, when the patient was received, the team had to review. The team was to review and say, okay, what do you want for this lady? Now, looks like in their case, they wanted active care, okay? They wanted active care, and that is okay. You don't have to convince them otherwise. You just have to work with them, yeah, for as long as the patient is going to benefit. So if they say we want the patient intubated, yes, you're going to go ahead and intubate, because for them, that is their desire. So you will go ahead, you intubate. Now, when you reach a point where you feel that the patient is okay, the patient can now go into the post-ICU care. If for you as an anesthesiologist, you think it is feasible for them to have, yes, the assisted ventilation outside the ICU, the other principle of geriatrics comes in, that in geriatrics, you should be able to care for the patient in an environment that is suitable to them. Usually we want their natural environment. That is why there are nursing homes. That's why there are retirement homes. Now in those advanced, countries, the nursing home, in the nursing home, you're able to give even the assisted ventilation. So if they have the ability to have this assisted ventilation in their home, it is very okay. You can go ahead and take care of them there. But then they will have to involve the different physicians or the different anesthesiologists to come in and review the patient depending on what they're able to support. So if they're able to support an anesthesiologist or intensivist to come in once in a while, a geriatrician to come in, a physiotherapist to come in and review the patient, it is acceptable and it is allowed, because that is one of the principles of geriatric care, to take care of the patient in the comfort, in their natural environment. That is usually our aim. That's why we also emphasize, as much as possible, let's try to reduce on the length of hospital stay. Thank you.
Thank you very much for that answer. We'll come back to that. I just want to clarify something from Dr. Fiona. So how did you guys go about that with that patient, doctor?
There were several meetings. She came in acute respiratory failure, but had also the background of the frailty, COPD, mainly those. She didn't have diabetes or hypertension, but pretty much very old, but with a very supportive family willing to do anything and everything for her. So discussions went on and on, but by that time she was intubated and mechanically ventilated, sedated, and showed some improvement, but because of the manifestation of disease, she also had got sepsis at some point. So with all that, about 3 weeks of still more and more discussions on goals of care, still family was opting to think that whatever can be done, they're able to pay for it and continue with the intervention. She eventually had a tracheostomy placed. The family, so there was now time for transition. She didn't need much respiratory support, but because of the background, as we've seen in the physiology, she couldn't clear off much of, she needed some respiratory support by a ventilator, at least CPAP. So the family bought a portable ventilator, and so the plan was now to transition home. So now the care was to plan how basically the teams will be going home, which is in Rukungiri, to review her. Unfortunately, she passed on before that would happen, because she still got intra-hospital, associated infections, and couldn't pull out from that. But basically, that was now the challenge, to put her in her normal environment in Rukungiri, and then have the teams to review her with the supported ventilation and all. So that's how far it went.
Okay, I know that you were conflicted. I would like to think so. I like you think that you're conflicted as a physician with the knowledge of physiology, disease, pathology, and the like. And you had an idea about the prognosis and the difficulties in the journey of this patient. How did you manage that conflict as a physician, in a sense that in a setting where the family is adamant and they are speaking money, and you're in a business setting? I mean, you guys can make money the more you keep this patient alive. How did you, as a physician, navigate that conflict, doctor?
Oh yeah, it was pretty difficult, and I was about to mention, following Dr. Timothy's story, that I think sometimes we focus more on the outcome of mortality and necessarily on morbidity. So somehow it biases the way we look at the geriatrics. But still, in a case where still another setting came in, and then the prognosis looked poor. Honestly, I felt like we were not going to do much for her, and despite several people, myself and other teams, communicating this clearly to the patient, they just seemed to think, I mean, for example, if you'd say that she would need more and more time on the ventilator because she cannot breathe adequately on her own, then the family will say, so is there an option of a ventilator? We can procure one. So you get what I'm saying? Not something like, okay, let her be on something. We gave all sorts of examples during the conference, but still, still the family was. Sorry?
Yeah, it's a living dilemma in every doctor's situation, and I guess what I'm trying to drive at is just to understand the difference in practice in terms of arriving at care decisions in the heat of the moment. And certainly, I think what you guys did here is never let the discussion or the dragging on delay the appropriate care the patient needed. You provided care while you hoped to arrive at a better decision. There's definitely an ethical principle allowing us to, an ethical tenet allowing us to withdraw any care that is eventually deemed to be inappropriate to a patient who has already started receiving it. For example, if you intubated a patient and found out they have extensive metastatic carcinoma, you may be able to withdraw that care once you've established the facts. But yeah, I just wanted just to appreciate how the different practitioners in ICU get this picture, because especially in private practice, people love their parents so much. And I see on the chat, Dr. Peter Gaba is already throwing in a comment that sometimes it's not good to just postpone death. And and there's a response that Dr. Peter Gaba loves euthanasia. I guess I want to take this question out of just a little bit away. I know Dr. Winnie is still in the background. I want us to discuss how we arrive at the goals of care for patients. Maybe Dr. Winnie, starting with you, might there be specific morbidity mortality differences in the same age group depending on the type of disease or system that's specifically affected? Let's say geriatric patient, acutely ill. Let's take an example of sepsis. The primary source is, say, lung versus, say, abdominal sepsis versus, say, renal urosepsis. Is there any data in geriatrics that suggests that these patients might have different mortality, morbidity indices, so that they might guide a limited ICU admission? Dr. Winnie?
Okay, let me try to answer that. Now, it still takes us back to geriatric syndromes. For each older patient that you see, you must assess and see if the patient is frail or not. In the event that the patient is frail, usually the outcome is worse. So mortality is likely to be high, is higher actually. It is higher than one older patient who is not frail. So it's important to know who is frail, who is not frail. Then it takes us back to those assessment tools for frailty. So whichever patient you get, you need to assess and see, are they frail or not? If they're frail, you're likely to get a worse outcome compared to the one who is fit. So that is important. I don't know if that kind of answers your question.
Yeah, partly, I guess the question I'm really asking is, for the same patient with the same frailty score, would their chances be different if, for example, they turned up with urosepsis and septic shock due to urosepsis, or due to abdominal sepsis versus respiratory? Yes, we know this exists more in the we know this exists in the younger population. Abdominal sepsis will probably be much nastier than maybe respiratory, which may be much nastier than urological sources. But I'm just wondering whether there's an age at which everything becomes brittle and the mortality approximates the same for the same level of frailty.
For that, I would say not necessarily. There's a general phenomena that as you age, your physiological reserves reduce. But not everyone who is old, okay, will respond the same way. You might get a patient of 104 and then a patient of 89. They're having the same condition, but the patient of 104 is likely to survive the condition more than the other. So it's not necessarily that when you clock a particular age X, then everything goes down. No, I haven't come across that literature. Maybe if someone else has come across that particular literature.
All right, thank you so much. I have a 107-year-old who keeps coming in and bouncing out of the ICU. The only thing that we have is that lately he doesn't remember our names, but every time it comes to respiratory illness, he gets out, doesn't even need to go to ICU. I mean, he's good. At some point, he came in with a heart block, with heart rate as low as 20 something to 30, and he was in profound shock. He got his pacemaker and he's back to riding his bicycle in the village. So yes, I definitely, not all elderly people are exactly equal, and I guess that demonstrates a lot. Any further questions, gentlemen and ladies? Yes, so Dr. Timothy on the chat is giving his experience. Okay, imagine you have got a prominent politician at 85 who needs ICU at a 28-year-old, and there is only one ICU bed. What would you do? Let me ask Peter Gava. Dr. Peter Gava, what would you do in this situation? You faced this during COVID in the Molago Hospital. What did you do?
It's going to be about who's fitter and who's going to benefit most from the ICU care. Whoever that person is the one who gets the bed.
Okay, and when you are conducting your goals of care discussions, how do you present? Just give us like even just a pseudo conversation with family, how you approach presenting the facts to family and then asking them for their opinion on what they should do, what they should choose perhaps about the patient's care. How would you do that? This one particularly regarding intubation, regarding invasive therapies, regarding CPR.
Yeah, I think it starts off, of course, with presenting the situation to the family, whatever condition the patient has, and what their chances are given what you can do for them, and then trying to gauge their understanding of that information, and then asking them about the patient's values and preferences. And then from there on, I mean, we can start the conversation of what their expectations are and what the patient would have liked. And that can guide the discussion on goals of care. Yeah, it's difficult to give examples when you don't have an actual case, but that's how I would go about it.
All right, thank you. Dr. Cornelius, what do you do? How do you go about that conversation?
I think that's about the way Peter would go about it. I think the only difference, maybe the only addition I would say is oftentimes you'll be surprised. Sometimes the families actually are fully aware of what's happening to their patient, and therefore the likelihood that it will be an easy conversation is there. So one of the things that I do is to first establish what the family knows about the patient's illness, and what they think about it, and how maybe the patient, basically the same process of taking history, but trying to understand the level of illness, the duration of illness, what their thoughts are, and then of course going into everything else, and then trying to help them understand and see the potential pathway of the illness with treatment and without treatment, and then trying to understand of course the patient's values are extremely important at that point, but usually it's difficult for families that are less affluent and less educated. Even for those that are educated, it's really difficult. But establishing for them the scenario that they have to understand the limitations in care that is going to be provided is important. What over time I've come to learn or do is to not write off any patient, but try to tell the family that we are going to try what is called a trial of treatment within the ICU, set goals every 48 hours to try and establish what would be the 48 hours, and then at maybe another 48 hours. If we fail to achieve the goals at 48 hours, then we have to sit down and rediscuss the goals of care at that point, because then at least they are aware that, okay, the team has tried, they've done what they could, but maybe the patient is just not getting any better. So it ends up being a little easier on the family and the healthcare team in that sense. And so personally, if I'm in a situation where I can admit the patient, we do admit and then establish the goals of care in the next 48 hours. And the family has to be aware that if we don't hit those goals of care, then we have to discuss what next and what goals of care we're going to go for. So that makes it a little easier on everyone and on the family. Yeah.
Correct. This is just a nice approach. I like it. Now, the question is, when you have that family that's quite adamant, they are clearly probably choosing a route that is not that to the base of your understanding is not aligned with the patient's goals very well, and maybe you have got this limited resource. How do you handle that? Again, I guess I would like to refer back to the COVID era, where we had so many patients, limited resource, and everybody is dying for that resource. I wonder if you ever had any difficult decision-making times where someone so influential, so important, but seemingly not exactly aligned with your understanding of the patient's likely outcome.
That happened definitely in COVID. That's the big problem. Number one, Uganda is a very young country with a very young healthcare system, no specific policies to guide on the tertiary care, which is where ICU falls. So it's extremely challenging. And so one of the things we actually did during COVID as a multidisciplinary team, we actually drafted protocols of triage. Now, COVID, we have to understand, was a little out of the, well, not a little, it was out of the ordinary for all healthcare systems. And of course, it because of the nature of the disease, it comes with a time-pressured decision of ICU admission, where you do not have a lot of time to decide who gets in and who doesn't get in. It has to be tailored on some objective criteria to eliminate subjectivity. But of course, it would still have some bias. But what we did then was to draft up a triage algorithm that allows us to select patients who had the best odds of survival in the ICU, who would benefit the most from the ICU, and you basically tag them red, yellow, green, or black, and depending on the bed availability, everyone who is red would get in. So in such a situation, and of course Uganda is in that situation all the time with critical illness and ICU bed capacity. So in such a situation, when you have if you have a politician who needs a bed and you have a young man who needs a bed, of course you have to understand that Uganda being an extremely political country, if you get a phone call from the Minister of Health saying admit this patient, that is extremely difficult. Thankfully, I was never subjected to that situation. Of course, those situations are usually subjected to the people who are above, usually the administrators, who also just forward it down and up to maybe the head of the unit. But at that point, when we had politicians who never made it to the ICU, some of those who did, some were lucky to make it out, some were not lucky to make it out. Of course, the decision between a young man, those happen, and some of those decisions are made far above you, and country that respect the politicians a lot more than the wananchi. It so happens that they probably would get more access, which is unfair, and of course violates the whole principle of justice. But that's how the country is designed, unfortunately. So yeah, that's my input on that.
Thank you, Dr. Cornelius. I just want to hear on the other end if there's a different principle. I believe medicine is the same, but I imagine that with the background of practice, it may be slightly different, or there may be some different approaches. Dr. Timothy Muyimbo, he runs the critical care unit of Bombo Military Hospital. Might there be any unique approaches that are different from what the civilian hospitals do? Dr. Timothy?
Thank you, Erasmus. Am I audible?
Yes, I can hear you.
Like everyone has submitted, at the back of our minds and our training, we have the ethics, we know what we have been trained to do. But I was just typing a comment, agreeing with Dr. Cornelius. Somehow, you have to adjust to the system you're in, the current prevailing situation, and then put in human factor and see how you can meet both parties somewhere in the middle. Appear to do something or do something for both parties and reach an agreeable state. Now, our situation is a bit tricky and difficult. I may not be able to share much here, but we went through similar challenges. And imagine a very prominent, maybe general calling you and even sending someone to secure the bed, make sure the bed is there. But you have another person who no one knows. Because there's no one chasing this person, eventually you find that you're put in a hard place. But we had to make difficult decisions, and somehow we managed to pull through. But the most important thing is that even as you're waiting to get the best, do something. What I learned from my training in India is that you can do something with the little you have and get the same physiological outcomes or close to the same. It is realizing early and seeing what you can use to achieve close to the same result that you should have achieved. And maybe the older patient may naturally give way for the younger one. I don't know. But it's very tricky. Yeah, thank you.
Okay, that final part was just quite funny. Yeah, surely. Okay, now thank you so much for that. Those comments. I just wanted really to run through every member of the the critical care practice, at least the guys who lead practices around. That's why I was asking different people, and I guess we are already past our time. It is 4 minutes past 8. Dr. Winnie Ayenyo, thank you so much for honoring our invite. Unfortunately, we will not be able to hear from Dr. Arthur Pizera because we're out of time, but also he got caught up and couldn't join us. We hope that in future he will be part of our talks and will be able to give us a lot of nuggets that have helped him get where he is and hopefully help us up as well. To the presenters of today, thank you very, very much. Quite an interesting topic and one that we'd want to discuss forever. Dear to us because we are growing older. People like Cornelius are clearly showing signs. But also, this is the age when our parents are actually in that category, and we are responsible for them and decision making, care for them, and taking them to hospital, among other things, let alone the parts of what the common patient we're going to be receiving. The patient you're going to be seeing in that private ICU is the one who can afford, and most likely the one who has worked all his life and now has some money to afford your care in private practice. So definitely important for us to appreciate those facts. Dr. Batha, thank you for the case and the physiological expose. Dr. Waswa, thank you for the guidance on which tools we can use for scoring our patient. Dr. Winnie, for a beautiful talk on post-ICU care of these patients. The rest of the audience, thank you so much for your active participation. Thank you for the questions. We return, I would like to say, in about 2 weeks, because next week is interrupted by another beautiful session that will be an international program, the Scale Grand Round. It will be on Thursday. We shall be having a talk on diabetic ketoacidosis. So kindly join that talk and be part of the audience and ask questions, among other things, to at least beef up the conversation. It's a collaboration between Cambridge and the Ugandan practitioners. And that's also the program that's helping us get our fellows to training in the first world. So far, we have 2 fellows that side, and we're inviting others who are interested in critical care fellowships, both in pediatric and in adult ICU, to enroll, especially after your MED enroll. For those who are training, for those who are in practice, you can still reach out to myself or Dr. Cornelius. We can get into a program where we do some local tutorship and guidance over a period of about 1 year before you are eligible for possible external fellowship, maybe in Cambridge or in Vancouver, and also the WFSA opportunities in Canada. This is open to surgeons, to internists, to anesthesiologists, emergency physicians, and pediatricians. So don't believe that critical care can only be practiced by anesthesiologists. There's a lot that we can all do to make a difference. Thank you so much, everyone, and I wish you all the best today, and see you in 2 weeks' time. Thank you. Bye-bye.